Hello students, this is my first presentation for renal topic, and this presentation is not the only source for your for this topic. uh, I would be telling you all to highlight some portions in EG book, as well as giving you some class notes, and so this topic will be inclusive of everything. Based on couple of feedbacks, some students whom I believe are very smart and they process information very fast, they were of the opinion that I repeat in my slides a lot, but I can say to those students, I really apologize, but I cannot teach, I cannot change my style of presentation, because many students from your same class have been really appreciative of the fact that I go slow on my slides and they comprehend better. And I know every student have their own learning style and own way of processing the information. So I will be slow when needed and will repeat the information as needed. Um, Adequate kidney function is very important for a healthy body. So something can happen to bone, something can happen to muscles, something can happen to even brain if there is a coma or something. Still, there is a chance of survival. But if something happens to kidney, it's serious. And and if there is complete kidney failure and it's not treated, the death is inevitable. That will happen. Now, this slide will discuss a little bit about the structure and function of the kidneys, assessment, and the diagnostic studies involved. So let's go to the next slide. Now, the urinary system, or uh, the renal system, is mostly composed of the upper urinary system and lower urinary system. The upper urinary system consists of two kidneys and two ureters. The lower urinary system consists of a urinary bladder and a urethra. So there you will see that there are paired kidneys, and they are, you all know, they are bean shaped organs, and where they are located, they are located retroperitoneally. When they say retroperitoneally, that means it's behind the peritoneum and it's on either side of the vertebral column. So it starts from T12 to L3, and each kidney weighs around 4 to 6 ounces. So roughly around 115 to 175 gram, and is about 5 inches long. And the right kidney is at the level of the 12th rib, and the right kidney is lower than the left kidney. And there is a gland which lies on top of each kidney, and that gland is called adrenal gland. Each kidney is surrounded by a considerable amount of fat and connective tissue that serves to support and maintain the kidney position in the body. Now, let's and the primary function of the kidney is to regulate the volume and composition of extracellular fluid and to excrete the waste products from our body. Now, just remember, kidneys, apart from regulating the volume and composition of the extracellular fluid and excreting waste products from the body, kidney also functions as a regulator of our blood pressure. It also produces erythropoietin. It also activates vitamin D, and it also regulates acid-base balance. So kidney has multiple functions, and all these functions are vital for our body. Now the surface of the kidney Let's go to the next slide. I think I repeated all this which is on this slide. The that the kidneys, the whatever I explained in the earlier slide, it can be categorized in a term called macrostructure. So if we have to explain the macrostructure of kidneys, we'll say that it's bean shaped, it's located retroperitoneally, adrenal gland lies on top of each kidney, it's cushioned by fat and connective tissue, and there is a fibrous membrane over the kidney which is known as capsule. And these membranes, or this membrane of the capsule, is very important as it serves as a shock absorber. So if anything happens to the kidney, this capsule protects the kidney from any sudden force from any blunt object striking the abdomen or the back. So if somebody uh, strikes in the tummy or at the back, then to protect the kidney has a fibrous membrane over it, and it's called capsule. Now there is something also called hilus or hilus on the medial side of the kidney, and this is the place where the arteries and nerves enter, and this is the place where veins and ureters exit. So this is just a mention of a small structure about the entry, which serves as the entry site for the renal artery and nerves, as well as the exit site for the renal vein and ureter. So let's go to the next slide. And this is just a longitudinal section of the kidney. So it's cut in half, and they're trying to show you inside what is inside the kidney. The outer layer of the kidney is the cortex, and the inner layer is the medulla. The outer layer is termed as cortex, and the inner layer is called medulla. And the medulla you can see, consists of number of pyramids. So you can see it shows the renal pyramids. And the apices of these pyramids are called papillae or papilla. So you can see there is single one renal papilla there. So all these apices, the pointy part of those triangles, which is the pyramids, they are called papilla. And the apices of these pyramids, which are called papilla, is the place through which urine passes to enter the calyces. So you can see there is uh, that light colored place after in the continuation of the pyramids, which is called calyx. So from the pyramid, the apices of the pyramids, which are known as papilla, is the place through which urine passes to enter the calyx. And the minor calyces, they become broad and they merge to form major calyces, and then which forms a funnel shaped sac called the renal pelvis. So pyramids, then calyx, and then renal pelvis. So see how it's positioned here in the diagram. Now the pelvis, the renal pelvis of the kidney, can store a small volume of urine, which is like 3 to 5 ml. So this is what I need you to know about this diagram. Okay, so where there is cortex, where there is medulla, the pyramids, the papilla, the calyces, the renal pelvis, and the renal pelvis can store a small volume of urine, around 3 to 5 ml. So let's go to the slide 5th. Now we will talk about nephrons. When we are talking about nephrons, we can categorize it that we are talking about microstructure of kidneys, and nephron is a functional unit of kidneys, and each kidney contains approximately anywhere from 800,000 to 1.2 million nephrons. And a nephron is composed of um, three important structures, which are called glomerulus, Bowman's capsule, and a tubular system. Let's go to the next slide. Now this is um, a structure, like a structure of nephron, explaining you, uh, all the different mini structures inside it, uh, and it is also showing you the surrounding blood vessels. Now, the tubular system, it consists of um, the another tubule, which is called proximal convoluted tubule. It also consists of the loop of Henle, and it also consists of distal convoluted tubule and a collecting tubule. The glomeruli, Bowman's capsule, proximal tubule, and distal tubule, they all are located in the cortex of the kidney. The loop of Henle and the collecting tubules, they are located in the medulla. Several collecting tubules, they come together, they join, and they form a single collecting duct. And the collecting ducts, they eventually merge into a pyramid that empties via the papilla into a minor calyx. So this is what you can know about the functional unit of kidney, nephrons, along with the blood vessels. So I will repeat. The tubular system consists of the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule and a collecting tubule. So there are four: proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and a collecting tubule. The glomeruli, Bowman's capsule, proximal tubule, and distal tubule are located in the cortex of the kidney. The loop of Henle and the collecting tubules are located in the medulla. Several collecting tubules, they join and they form a single collecting duct, and then all these collecting ducts, they eventually merge into a pyramid that empties via the papilla into a minor calyx. Now let's go to the next slide. Kidneys. The blood supply of the kidneys is synonymous with a very important word for our body, and it is called cardiac output. So blood flow to the kidneys, approximately 1200 ml per minute, accounts for 20 to 25% of the cardiac output. And how is the blood reaching? Blood reaches the kidneys via the renal artery, which arises from the aorta, and it enters the kidney through the hilus, or the hilus or hilus. The renal artery then divides into some secondary branches and then further into smaller branches, and which forms something called afferent arteriole. The afferent arteriole then divides into a network of capillaries, which is known as glomerulus. And it's afferent, the glomerulus may be around like 50 capillaries, 50 capillaries might be there. So a blood supply of about 1200 ml per minute, which is 20 to 25% of the cardiac output, flows to the two kidneys. Blood reaches the kidneys via the renal artery, which arises from the aorta, and then it enters the kidney through the hilus. The renal artery divides into secondary branches and then further into more smaller branches, and then it eventually forms an afferent arteriole. The afferent arteriole divides into a capillary network which is known as glomerulus, and which is just a tuft of up to like 50 capillaries. And then capillaries of the glomerulus, they eventually unite in the efferent arteriole, which is EFFERENT, and this arteriole then splits to form a capillary network called the peritubular capillaries, which surrounds the tubular system. And all peritubular capillaries, they eventually drain into the venous system, and then the renal vein empties into the inferior vena cava. So that's how the blood supply in the kidney happens. Let's go to the next slide. So next slide. Now, physiology of urine formation. Well, it all comes down to this slide. Why we need to know about so much about kidneys, because urine formation is happening over here. And what is the urine formation? The process of urine formation in the kidney is very complex, and it is an outcome of various steps. So there is filtration going on, there is reabsorption going on, there is secretion going on, there is excretion of water, electrolytes, and other waste products are going on. Although urine formation is a result of all these processes, the primary function of the kidneys is to filter the blood and maintain the body's internal homeostasis. So now, the hydrostatic pressure of the blood within the glomerular capillaries. There is within the glomerular capillaries, there is a pressure, hydrostatic pressure, and it causes a portion of the blood to be filtered across the semi-permeable membrane into Bowman's capsule, where the filtered portion of the blood, which now becomes the glomerular filtrate, it begins to pass down to the tubule. And the amount of blood which is filtered each minute by the glomeruli is expressed as the glomerular filtration rate. The normal GFR is about 125 ml per minute. And when they are looking at the labs for the patient who has some kidney disease or renal disorder, they closely look at GFR, which is the glomerular filtration rate. Now let's go to the next slide. Tubular function. Now, tubules and collecting ducts, they carry out the functions of reabsorption and secretion. Reabsorption is the passage of a substance from the opening of the tubules through the tubule cells and into the capillaries. This process involves both active and passive fluid transport mechanisms. Tubular secretion is the passage of a substance from the capillaries through the tubular cells into the opening of the tubule. Before we move to the next slide, let's review some functions of the segments of nephron, which we just learned about. Now, we've talked about glomerulus. Now, the job of glomerulus is selective filtration. So it does selective filtration of the blood. Then proximal tubule, it does the reabsorption of the 80% of electrolytes and water, and reabsorption of all glucose and amino acids reabsorption of bicarbonate, and secretion of hydrogen and creatinine is all done by proximal tubules. Loop of Henle. Loop of Henle does the reabsorption of sodium and chloride in ascending limb, and also it does the reabsorption of water in descending loop, and it also does the concentration of filtrate. Distal tubule, it does the secretion of sodium, hydrogen, ammonia, and it also does reabsorption of water, regulation of some phosphates. Collecting duct, it does reabsorption of water. So these are some of the structures or segments of the nephron, and each segment is doing the function of filtration, reabsorption, secretion, keeping in the nephron what the body needs, and then slowly taking out what the body doesn't need. So let's go to the next slide. Other functions of kidney are red blood cell production, which is a very important function. So as soon as somebody has problem with kidneys, we want to go and look at their RBCs. Erythropoietin is a hormone produced in the kidneys and secreted in response to hypoxia and decreased blood flow. Erythropoietin stimulates RBC production in the bone marrow. So we need erythropoietin in our body, because of the existence of erythropoietin, we have RBC production. The kidney does the blood pressure regulation, and there is the hormone called renin, and renin is important in the regulation of blood pressure. Renin is produced and secreted by cells of the kidney, which are known as juxtaglomerular cells of the kidney, and then renin is released into the bloodstream in response to decreased renal perfusion, decreased arterial blood pressure, decreased extracellular fluid, decreased serum sodium concentration, and increased urinary sodium concentration. So whenever there is low kidney perfusion, low arterial BP, low extracellular fluid, low serum sodium concentration, and high urinary sodium concentration, then renin will be released into the bloodstream. And what does renin do? Renin activates angiotensinogen, which is from the liver, to angiotensin 1, and then angiotensin 1 is subsequently converted to angiotensin 2 by angiotensin converting enzymes, and then angiotensin 2 stimulates the release of aldosterone from the adrenal cortex, which causes sodium and water retention, which leads to an increased extracellular fluid volume. Angiotensin 2 also causes increased peripheral vasoconstriction. Release of renin is inhibited by an elevation in BP, in blood pressure. So this is how renin plays a very important role in blood pressure regulation. So the two functions which we reviewed are RBC production and blood pressure regulation by the kidney. Let's go to the next slide. Structures and functions of the urinary system. Ureters are tubes that carry urine from the renal pelvis to the bladder. The narrow area at which point each ureter joins is called the renal pelvis, and it is also termed as uretero-pelvic junction, and subsequently the ureters insert into either side of the bladder base, and the narrow ureteral openings can be easily obstructed internally. So it can be easily obstructed internally from inside by any urinary calculi or externally by any tumors, inflammation, etc. Bladder, the urinary bladder is a very stretchable, able to fill at relatively low pressure. So it is very stretchable organ which is positioned behind the symphysis pubis, and it is anterior to the vagina and rectum. Its primary function is to serve as a reservoir for urine and to eliminate waste products from the body. Normal adult urine output is approximately 1500 ml per day, which can vary with food and fluid intake. The trigone is the triangular area formed by the two urethral openings and the bladder neck at the base of the bladder. The bladder muscle, which is detrusor muscle, it is composed of layers of um, all intertwined smooth muscle fibers which are capable of considerable distension during bladder filling and contraction during emptying. So the bladder muscle detrusor is helps in distension of bladder when the bladder is full or when the bladder contracts to release the urine. Bladder capacity varies with the individual, but generally it ranges from 600 to 1000 ml. And when the urine comes out, it is known as urination, micturition, or voiding. So urination, micturition, voiding are same. Okay. So and just so you remember, bladder's capacity is 600 to 1000 ml, but that's separate from the thing that normal adult urine output is just approximately 1500 ml per day. And this is a picture of urinary bladder, and you can see the smooth muscle, the detrusor muscle here. Think about the time if something happens uh, to the nervous system, or something happens to the nerves which control these muscles, then how much problem the patient can have taking the urine out. We are coming to urethra. It extends from the bladder neck to external meatus, and this is the conduit for urine during voiding. And in female, we all are familiar with it because of the lot of practice in skills lab due to Foley insertion. Female is 1 to 2 inches, which is approximately 3 to 5 centimeter. In male, it's 8 to 10 inches, which is approximately 20 to 25 centimeter. And this is what you need to know about urethra. Let's go to the next slide. Now, what is urethrovesical unit? The urethrovesical unit is formed by bladder, urethra, and pelvic floor muscles. And voluntary control of this unit is defined as continence. And distension of the bladder stimulates stretch receptors, and impulses are then sent to brain. Now, the stimulating and inhibiting impulses are sent from the brain through the thoracolumbar and sacral areas of the spinal cord to control voiding. So from T11, that is T is in table, from T11 to L2, and then from S2 to S4, to these parts, the brain is sending some signals, and then that's how the the voiding is happening. So distension of the bladder stimulates stretch receptors within the bladder wall. Impulses are transmitted to the sacral spinal cord and then to the brain, causing a desire to urinate. And if the time to void is not appropriate, inhibitor impulses in the brain are stimulated and transmitted back through the thoracic, lumbar, and sacral nerves, which are in the bladder, and in a coordinated manner the detrusor muscle accommodates to the pressure, and the sphincter and pelvic floor muscles tighten to resist bladder pressure. So when the in nutshell what they are saying is that if the bladder is full and we know and we control it, that we are not taking it out, it's because there are some signals being sent to the brain which command some nerves and some muscles in the bladder, and that's how there is a resistance and the urine doesn't come out. If the time to void is appropriate, cerebral inhibition is voluntarily suppressed and impulses are transmitted via the spinal cord for the bladder neck, sphincter and pelvic floor muscle to relax and for the bladder to contract. When the bladder is empty, the sphincter closes and the detrusor muscle relaxes. Now, I explained it in a little complex way here, but the thing is that there is um, for there is something called voluntary control of this unit, which is urethrovesical unit, and there is something called involuntary control of this urethrovesical unit, and this will um, synonymous with a thing called continence or incontinence. Next slide. And while we were discussing about continence and incontinence, we want to know about the gerontological considerations of urinary system. It says anatomic changes in the aging kidney include a 20 to 30% decrease in size and weight between the ages of 30 and 90 years. By the seventh decade of life, 30 to 50% of glomeruli have lost their function. So by size and weight of kidneys decreased 20 to 30% between 32 and 90 years of age. And by 7 decade, by 70 years, loss of 30 to 50% of glomerular function is there. If somebody has atherosclerosis, it will speed up the process of decrease in size of kidneys with age. Let's go to the next slide. As it says, there will be a decreased renal blood flow, and which will result in decreased GFR, and there will be also some altered hormonal levels in the body, which results in decreased ability to concentrate urine, and there is also altered excretion of water, sodium, potassium, and acid, and all these electrolytes are very important for our body to maintain balance. Physiologic changes in the aging kidney include decreased renal blood flow and caused by atherosclerosis, resulting in decreased GFR, and there is also something called the elasticity. The female urethra, bladder, vagina, and pelvic floor undergo a loss of elasticity and muscle support. Consequently, older women are more prone to bladder infections and incontinence. Now, as men age, the prostate enlarges and may affect urinary patterns, causing hesitancy, retention, slow stream, and bladder infections. And yes, I have seen people with blockage in the urinary system, in enlarged prostate, anything happening around there. Prostate gland is very close to the urinary system. Anything happening there, how painful it becomes for the patient to void, for the men to void, and with that, and we as women, we might have come across or have experienced the UTIs, and also seeing maybe incontinence in older women um, on the floors or around us. Assessment of urinary system. We need to question the patient about the presence or history of diseases that are related to any kidney or any other urologic problems or any trauma. And some of the diseases which can affect the functioning of kidney are hypertension, diabetes mellitus, gout, any connective tissue disorders. So if there is lupus, then or TB, congenital disorders, and neurological conditions, they all will affect kidney. And think about BPH, benign prostatic hyperplasia, some infections, and it's very important also to assess the patient's current and past use of medications, including over-the-counter drugs as well. And while I'm here, I want you to go. I have my notes here, which tell you about the potentially nephrotoxic drugs. So the common nephrotoxic drugs which we can see are, like, if the patient is on these, then you can see what it can affect kidneys, or they are toxic to kidneys. And some of the antibiotics or antibiotics or antibiotics, some of them are all the mycin, gentamicin, kanamycin, neomycin, tobramycin, vancomycin. They ask you in NCLEX a lot about how these mycin, the drugs that again mycin are nephrotoxic. Bacitracin, that's also toxic to kidneys. There is also other kind of drugs which are toxic to kidneys. This is rifampin. You all know what rifampin is. Lithium, cyclosporin, cocaine, then capoten, which is captopril, cimetidine, which is tagamet. They say there is also metals, other agents which are very toxic to the kidney, and gold, and also contrast medium. So contrast medium is also toxic to the kidneys. Um, you can ask the patient about any previous hospitalizations related to renal or diseases. Um, ask about the duration, severity, and patient's perception of any problem and its treatment. As you all know, you need to document all any past surgeries or any catheterization, urinary catheterization was done. Ask the patient about any radiation or chemo treatment for cancer being done. Next slide. Subjective data. Um, Subjective data, we can start with health perception. So how is your energy level compared with a year ago? And then you can say, do you notice any visual changes? Have you ever smoked? So these are some of the health management pattern questions. You can ask about their nutrition metabolic patterns. So how's your appetite? Has your weight changed over the past year? Are you taking any vitamin supplements? And how much of water you have every day? How much of dairy products? How much meat? Steak, steak. Do you drink coffee, chocolates? How much spices you take? How much, sodium? Um, Now, elimination pattern. And then elimination pattern, you can say, are you able to sit through a 2-hour meetings or ride in a car for 2 hours without urinating? Do you get up at night to go to pee? Do you ever notice blood in your urine? Do you ever leak urine? Um, do you ever have pain when you are urinating? Do you ever experience constipation, or hard stools that are difficult to pass? Um, do you frequently experience kind of diarrhea? And we can get some information about the activity exercise pattern. That have you observed any change in your activities of daily living? Are you stopping a lot, in between certain activities? Do you require assistance in moving or getting to the bathroom? Let's go to the next slide. Sleep rest pattern. So sleep rest pattern is kind of same, like it's kind of same under the from the elimination pattern. Do you get up at night to go to a bathroom? Do you get up at night from pain? Or are you experiencing any daytime sleepiness and fatigue as a result of nighttime urination? And then you can ask questions about a cognitive perceptual pattern. Describe any pain you have in relation to urination. Then you can ask them about their self-perception, self-concept pattern. How does your urinary problems make you feel about yourself? Do you perceive your body differently since you have developed this problem? Role relationship pattern. Um, is it affecting your relationship with family or friends, or or you're not able to go out that much with your partner or with kids? Sexuality, reproductive pattern, and has urinary problem caused any change in your sexual performance or pleasure? Do you have any hygiene problems related to sexual activities that are causing this concern? Coping, stress tolerance pattern, which is in the next slide. I think I missed it. Well, we can also ask them about the coping stress, how they are coping with the stress, and any belief system about their elimination. Objective data, you all know it's inspections. We'll go from skin. We'll say gay skin will be pale, yellow gray cast, changes in any turgor, bruises, any rough skin, mouth. You can look for any stomatitis, any ammonia, any breath odor. So you will look at the general state of health and weight gain, if there is any weight gain secondary to edema, weight loss, or muscle wasting. Um, General state of health will also look, you will see for any fatigue, lethargy, diminished alertness. Um, Left kidney is rarely palpable. The kidneys are posterior organs protected by the abdominal organs, the ribs, and the heavy back muscles. A landmark useful in locating the kidneys is the costovertebral angle formed by the rib cage and the vertebral column. So anytime you have to uh, do an examination of the kidneys using palpation, we are looking at something called CVA, which is costovertebral angle, which is formed by the rib cage and the vertebral column. You'll see it in the following slide. So that's a landmark to assess the kidney function. The normal size left kidney is rarely palpable because the spleen lies directly on top of it. So because of spleen lying on top of it is really palpable. Right kidney may be palpable, so you'll see in the next slide. The urinary bladder is normally not palpable unless it is distended with urine. If the bladder is full, it may be felt as a smooth, round, firm organ and is sensitive to palpation. So let's go to the next slide. To palpate the right kidney, place your left anterior hand behind and support the patient's right side between the rib cage and the iliac crest. That's the way it's showing in the picture. And then elevate the right flank with the left hand, and then use your right hand to palpate deeply for the right kidney. The lower pole of the right kidney may be felt as a smooth rounded mass that descends on inspiration. So if the kidney is palpable, note its size, contour, and tenderness, and this comes with practice. Kidney enlargement is suggestive of any, you know, neoplasm or any renal disease condition. Let's go to the next slide. Objective data, physical examination, we'll go for percussion uh, and which will involve kidney punch and bladder. Now, tenderness in the flank area may be detected by fist percussion. So it's also called known as kidney punch. You'll see in the next slide. This technique is formed by striking the fist of one hand against the dorsal surface of the other hand, which is placed flat along the posterior CVA margin. So during your physicals, a good doctor will usually do that. Normally a firm blow in the flank area should not give out any pain. The presence of any tenderness and pain in that area may indicate any kidney infection or polycystic kidney disease. Normally a bladder is not percussible until it contains 150 ml of urine. So if the bladder is full, dullness is heard above the symphysis pubis. So there should be a dull sound in the bladder. A distended bladder may be percussed as high as the umbilicus. So this is what they are doing, the kidney punch, you know, percussing. This is percussion. Next slide. Auscultation. The bell of the stethoscope may be used to auscultate over both costovertebral angles and the upper abdominal quadrants. With this technique, the abdominal aorta and renal arteries are auscultated for any bruit, which is an abnormal murmur. And if there is a bruit, it will indicate any impaired blood flow to the kidneys. And you can use the diaphragm of the stethoscope to auscultate the bowels, because they too may affect the urinary system. Assessment of the normal physical assessment of the urinary system should say there should be no tenderness at CVA, non-palpable kidney and bladder, and no palpable masses should be there. Now there are some of the terms which I want you to just review for this is anuria. So I want you to know what anuria is, which is technically no urination or 24-hour urine output less than 100 ml. And then what is dysuria, which is painful or difficulty urinating, hematuria, blood in the urine, nocturia, frequency of urination at night, incontinence, inability to voluntarily control discharge of urine, oliguria. What is oliguria? Diminished amount of urine in a given time. So in 24 hours the urine output is from 100 to 400 ml. If it is 100 to 400 ml, it is oliguria. If it is less than 100 ml, it's anuria. Polyuria is large volume of urine in a given amount of time. And what is stress incontinence? It is involuntary urination with increased pressure, so like sneezing or coughing. Next slide. Urine studies, urine analysis. Um, the first morning void is important. It's better to have the first morning void, and it's examine urine within 1 hour. So, and then creatinine clearance, it collects 24-hour urine specimen. Creatinine clearance closely is, it's approximate to the GFR. Urodynamic test is the study of the storage of urine within the bladder and the flow of urine through the urinary tract to the outside of the body. A combination of techniques may be used to provide a detailed assessment of urinary function. Urine analysis is a very common test which is done, and even we can see from a naked eye if there is any sediments or any blood in the urine. So it's a very common one. Blood specimen for serum creatinine determination should be obtained during the period of urine collection. So urodynamic studies, they measure the urinary tract function. So regarding the diagnostic studies, I will ask you to highlight something in the e-book. This is the first picture. They are showing a flexible cyst nephroscope, and second picture they are showing a scope which has been inserted into the bladder. And there is a diagnostic study called cystometrogram, and for that I will ask you to highlight something in your e-book. Patient is scheduled for cystometrography. Which instructions will the nurse provide to the patient about this procedure? What is cystometrography? It's in simple terms, it's an evaluation of bladder tone, sensations of filling, and bladder stability. So out of these options, what is the correct option? So which instruction will the nurse provide to the patient about this procedure? The answer is B, B as in baby, that water will be instilled into the bladder through a catheter to assess bladder tone. This brings us to there's one more question. The nurse is caring for a patient who has just undergone cystoscopy. Which Assessment finding necessitates an immediate intervention by the nurse. Bright red urine, it's B as in baby. We never want bright red urine because um, there's going to be some kind of bleeding going on. Burning on urination, urinary frequency, and back pain, they are expected findings, expected effects of cystoscopy. Okay, so this brings us to the end of this presentation. Thank you.